I guess there would be some new members joining. So just housekeeping rules, like we do every day. Mute yourselves for the call, and unmute only when you're asking a question or getting an answer. Would appreciate that. And like Vaibhav said, this was a recorded session. So people who want to go back to, getting the details of some questions that have been answered by our specialist doctors who we have done now and in the past, can go back to UK Lifesaver YouTube channel, and that is posted in 2 hours, 3 hours from now. So without much ado, I would hand it over to Vaibhav to give a brief introduction. Everybody knows Sanjeev and Vineeta from the OMPEC group, but there are participants who are outside of the OMPEC platform also on this call. So it will be nice if Vaibhav, you can give a small introduction, and then we can rightly get into the call. Thank you.
Yeah. Thank you, Santosh. So Mr. Sanjeev is the legend. He has done his MS, then MCH from Liverpool, and then he has done his MRCS, FRCS, general surgery, FRCS, trauma and orthopedics. He's specialized in hip and knee surgeries. So we have that privilege today that he joined us, and same with Mrs. Manjure as well. So Vineeta she has finished her MBBS, MD, then FRCOG. Sorry, and then she has done the GP as well, and she's currently practices a GP surgery. So yeah. So thank you for joining today. So we're gonna give it to Mr. Sanjeev, please. Okay.
Thanks for your kind introduction, Vaibhav.
Yeah. So we had the first question. So some of the members wanted to know how the COVID-19 has made an impact, and as we were discussing earlier, the use of virtual fracture clinics and the use of minor injury unit lead by the orthopedics, how that had created an impact onto the emergency services. How do you feel about it, and what will be your advice for the future, not just for the UK but for the other countries as well?
Sure. So it's made a huge impact currently. So what has happened is all the elective work, that is planned work, including clinics, have been put on hold. So any elective operations, so hip replacement, knee replacement, up shoulder, or anything which is a planned operation which doesn't need emergency involvement, that has all been cancelled or put on hold. As far as the clinics are concerned, what we have done is we have started audio consultations, and soon we'll be starting video consultations with patients. Obviously, the NHS, with the regulations, it's very difficult to introduce something new like video consultations without all the regulations being in place. So that is taking some time. But this morning I did the clinic audio consultation, teleconsultation clinic, and it went on very well. So these are patients who have been either operated in the past, or some of them were new patients who were referred by the GP. So from that point of view, the elective work is still going on, but no operations. On the side of the emergency, so fractures or other injuries, limb injuries which come, or acute back pain with some in causing some nerve issues or weakness in the limbs, that is still being dealt with, though no operations. The only operations in the last 2 weeks we have carried out are elderly patients with hip fractures. As regards your question of what else, the minor injuries, so children with fractures or any adults with injuries, like yesterday we had a gentleman changing the light bulb and fell down and dislocated his thumb. So those are the things which are still coming through the door. So previously what used to happen was the accident and emergency clinicians like yourself, Vaibhav, you used to look after all these patients, and then we used to follow them in the fracture clinic. But now they are directly seen by us, so that you guys can then concentrate on the really uh, sick patients.
Hmm.
um,
So Sanjeev, we
and
can just ask you a question too
yeah,
early in the Q&A, but since you're saying that surgeries that have been pushed out in terms of the lead cycle time, so if there is somebody who have private insurance, like I have private insurance, and I was planning on a C5 C6 since last December, but I canceled it for various reasons. So if having said that, if I do go in and talk to my doctor and schedule one in the next couple of weeks based on his availability, is there a possibility that that would happen, or because it's a private insurance, everything is put on hold? Because your
so
NHS thing is still going on with a pushed out date, right? So,
yeah, no, all private hospitals, all the planned operations are all put on hold as well. So whether you have
okay.
insurance or not, everything is on hold. So none of the I do some private work as well. So all
Hmm.
that is completely on hold. There is no, the hospitals have actually been assigned to NHS. So
Oh, okay.
staff have been QP'd to the NHS, and also some of the beds where there are facilities, they have been assigned to NHS. So some NHS patients, which like for instance Northampton, what they have
Hmm.
done is they have converted the private hospital into a minor injuries unit.
Okay.
So that is quite
Yeah.
impressive.
So
Mhm.
yeah.
So,
So no private elective planned work is being carried out across the country.
Okay. Yeah, because
yeah.
I have this surgery being planned, and which is critical. The reason that I'm pushing it out is for other reasons, but uh, I've been always told by our the neurosurgeon that if it becomes worse, because I have an intrusion into the in the C5 C6 where it's pinching the spinal cord, and it's pinched it really deep enough. So there is a caveat with the doctor saying that if you have a problem, you miss a step or you have a jerk reaction, it could be lethal, and if that happens, so then contact the A&E. So I'm just thinking out loud. At least I'm okay with. I cannot give you the lot of details, but
Mhm.
worst case scenario, if something like
Yeah.
that happens, it
Yeah.
would be going to the
Absolutely.
A&E,
So
right?
if
Yeah. So I think
yeah,
Santosh
correct,
is
correct.
the main thing is it's in the cases of epidemics, life and limb threatening emergencies take over the other emergencies. So obviously, from the patient perspective, emergency might be anything like,
Hmm.
but as a clinician's perspective, if intervention is not done and if the
Hmm.
patient is dying, then that takes a priority.
Precedence. Okay.
Yeah, yeah,
Okay.
yeah. So
Okay. Got it.
there is a slightly, yeah, as a vested interest. Yeah.
Okay.
Okay. Mr. Sanjay,
But the
can you please elaborate?
Absolutely. So
Yeah, sorry.
if you develop any problems, I mean, I hope you don't,
yeah.
but in case there is a problem, then absolutely emergency, any you can go to, because any life limb threatening will
Hmm.
be dealt with and will be sorted at that time,
Yeah. But having said that, you're saying that all planned surgery. If I try to plan a surgery in the given
No,
circumstances,
that is
that would not be
that
cued,
will not
right?
happen.
Okay.
That will
Okay.
not happen. And in fact, the today there was a conference call with the National Orthopedic team across the country from each hospital, and they have said that any planned orthopedic surgery in the next few weeks, not just 2 weeks, but few weeks, and nobody specified what is few weeks. It could be
Hmm.
a month or it could be 2 months. This will not be a priority. The other pathologies, other conditions will take priority.
Okay. Okay. Makes sense. Okay. Thank you. Thanks, Sanjeev.
Mr. Sanjay, can you please elaborate more about virtual fracture clinic? I think you were trying
Yeah,
to implement that in last 2 3 years in one of the hospitals, but it
correct.
took little slow approach than the. I don't want to criticize anyone, but
Yeah.
what will your expert advise, not just for the UK's perspective, but in the other countries like India and the rest of the world? How do you think we should have how we can use our resources in a better way?
Correct. So there are lots of developments in various aspects of this. So one of the things is there are certain fractures identified which we know are very straightforward and they don't need any involvement of um, a orthopedic surgeon or a doctor after the first contact. They heal whatever you do. So those fractures have been identified, and these are the patients whom, once they are seen either in A&E or by the GP even, or even in by an orthopedic on-call team, they are then discharged home and they take off the bandages or whatever slings they are given on their own. So these are the patients who can then have a virtual consultation, either a video consultation or a audio if there is a problem. Then the second group of patients are those patients who can have a video consultation after 3 or 4 weeks of this sort of fractures, and they can then be discharged. So a face-to-face consultation can be avoided in this first two group of patients. Then the third group of patients would be those who would need a regular follow face-to-face follow-up. So the first two group constitute about 50 to 60% of the patients. So these are the patients who can easily be um, sort of managed with new technologies.
Okay. And do you think that, I think you're gonna do have a venture coming soon for the, do you want to do like, do you want to give a brief idea about what gonna come soon from your end, like in the future, like what we can.
Yeah, so
Mhm.
yeah, so I think some of the OMPEG guys might have known. Couple of years ago, we did a presentation in the Danube Hotel where we floated the idea of a video consult for patients. Currently, this is for patients in UK, but also outside UK for second opinion. So anybody who has got orthopedic condition or any condition, not just orthopedic, this is all specialties, they can ask for this video consultation through this platform. So we'll be soon launching this in a couple of months' time. It has been a bit delayed because of the legal. We want to get the legal side of it right. As you know, with video consultation, there are a lot of legal aspects and also information governance aspects to be covered.
Mhm.
So we'll be launching this platform for patients who can consult doctors from GPs to any specialty through this platform.
But will that be covered by insurance, those kind of modalities, or will it be pay on demand kind of thing?
There will be initially it will be a self pay, but as we go into it, we will be sorry, sorry, Vaibhav, you're saying something.
No, it's basically, I think I don't know, it's not saying anything. So I think the as you said, like probably it might be initially pay as go, and as the things grow, might get tied up with the insurance company. So it will be good for patient's perspective as well.
Correct, correct.
Yeah, doctor, will this be like under not I won't say umbrella, but will it be like under supervision or under authorization of NHS? Like suppose if you prescribe something on a video call, and am I able to like get it on a counter on a pharmacy, or if I go for NHS for further review, will they approve accept this consultations stroke prescriptions?
So this will be this won't be NHS. This will be a completely private service. This won't be an NHS service, really.
And I think that also varies from person to person. There are a lot of, it's a complex thing, I think. But as the time comes, I think we will be we can throw more light on it.
Yeah,
Okay.
thanks.
But
Mm.
is the main purpose where there is a need that you see is on the wait time that is there in the NHS. So are you trying to kind of address that issue with the NHS to getting people access to
Part yes,
consultations.
one of the thing is that, and also as I said, there are various conditions where you don't really require a face-to-face consultation. So somebody could be sitting in Glasgow and they need an opinion from a doctor. They could be here down in London, and they could have a consultation here. So there are certain conditions where they don't need a face-to-face consultation, and those are the patients whom we can easily manage.
And also on top of that, like what we have seen in the past, like say for example, I'm a clinician in UK. I'm seeing one particular patient, and if say for example it's very complex condition, for example a typical HUS. I'm not going into in depth of the particular clinical condition, but if it's a complex condition, then a doctor sitting here can liaise with the doctor sitting somewhere else, or vice versa. Like if guys there in other country, so like Saudi or somewhere else, and they can liaise with the UK experts, and the UK experts can give expert advice to what they are doing and what can be done in future. Mm. Is that correct, Mr.
Absolutely.
Sanjeev? Yeah. So there was another question asked by one of the colleagues. Like we know that the back pain is quite critical. Like normally, some most of the people can have the back pain and it can get resolved. We ask them to be active and not to be have a sedentary lifestyle. But considering the COVID-19, where home isolation is strictly advised and the quarantine is been recommended, how do you address that from staying at home but still like being active? So what will be your advice, and can you tell, some of the people were asking what exactly red flags mean for backache?
Okay, so majority of the back pain can be treated without any major intervention. So painkillers and physiotherapy exercise can treat majority of the back pain. So only patients where there is a sudden acute back pain with going down the legs and also having problems with their waterworks, with passing the urine or opening the bowels. That is when the you start having you need to get some advice. Otherwise, most 80% of the back pain you could manage initially without going to the A&E.
Okay.
Or any GP. Yeah,
Yeah, yeah,
yeah.
yeah. Okay. And obviously, like there are other things, like if somebody do not like if they lose control of their bowel and bladder, then they need to come to A&E to make sure that what, as you said earlier, to rule out what you call as Cauda-Equina syndrome. So that is like emergency which needs to be addressed within 24 hours. So those patients who have severe back pain but they lose their like strength in the leg, so lose in the sense like if they can't feel completely below a particular level, or if they lose the control on their bladder, they started having either incontinence or retention sudden onset, then they need to visit A&E to sort out the thing.
Yeah. So those patients who are not able to pass water, those are the patients who may need to seek urgent advice either from the GP or A&E, because these are the patients where the nerves are being compressed and therefore they are unable to feel around the private parts, or they are unable to pass water. Sometimes they lose control over their bowel. So these are the symptoms which we call as red flags, where you need to go to consult a doctor immediately.
But do these happen sequentially, or what is the time period that you would start seeing it, and then when it would be really pronounced and you would actually call it a red flag, or does this happen
you
pretty fast?
these usually happen very acutely, meaning within 24 to 48 hours usually they happen. It can be over a period of 3-4 days, but
Mm.
you will know that because you won't be able to pass water at all, and you
Okay.
will have to. The pain would be very severe as well. Pain, back pain, as well as pain going down the leg,
Okay.
would be very severe.
Makes sense. Thank you.
Right. Okay. Um, any specific advice will you give for the patients who are elderly and they're living on their own, but if they develop any injuries, because they have been told if any cough, cold, fever, then obviously need to stay at home. Um, but any other specific advice from physiotherapy point of view? Because previously the physiotherapists used to go and visit, but now because of the home isolation, are you planning any video physiotherapies or something? Do you think will that be a good option?
Yes, so there is a video physiotherapy already planned. In fact, some of the physiotherapies are already doing teleconsultations. The video consultation thing is not yet available in our hospital, so currently they are doing only teleconsultation. And these are only right now only for some of the post-op patients, or some of the patients who have had problems in the past and have sought advice from the physiotherapist. But we are also seeing increasing number of patients, elderly patients, with hip fractures.
Mhm.
So even though they are indoors, because of um, lack of support, or difficult to sort of pinpoint as to why the numbers have gone up. Normally, we get about 2 or 3 hip fractures in a day, but in the last whole week, we have been getting on an average 6 or 7 hip fractures. So
Mhm.
it's certainly gone up.
And
The rate of elderly patients falling indoors have increased, and it's difficult to know why exactly.
Wow.
and there was another question was asked, whether do you recommend over the counter vitamin D and calcium tablets? Obviously, they have to go to GP and do their baseline. But considering current situation, what is your take on it?
So
You're
for
talking about elderly
elderly,
peoples?
are you talking
Elderly
about elderly
population,
patients
yeah.
or adult patients?
Eh,
Elderly
eh,
population. So
yeah.
so for postmenopausal women, just taking vitamin D and calcium is of no use, as you know.
Mhm.
Even for men, just for a short time, unless they have real deficiency, it's not going to be of any use. So unless they have been on these medications for a severe deficiency, I don't think that there is any point in just using this vitamin D or calcium for a short duration at all.
Mhm. So they should not do as a blanket treatment on their self. So I think that is a key message, that
No.
unless until the medications are advised, do not use the medications on their own. Otherwise, it might have its own implications. Yeah. Uh, I think if anybody has any questions, otherwise, Sam,
Yeah,
there's
yeah. So I think so, Sanjeev. So what would be your closing statements on this? In the sense, I know your number one would be don't fall anywhere, but in, in
No,
terms
no.
of
So,
just a
so,
caveat
so,
for
so,
everybody on the call.
yeah. So the closing statement is that, especially and I'm thinking more of from the from for those patients or people who are elderly. So all the young ones amongst the group here, we need to look out, keep a lookout for these elderly people we know. So do keep them, do call them regularly to find out whether they are well or not. Because what happens is the elderly patients who fall, what we are seeing is that they are people are coming to the A&E after 12 hours, 24 hours of the fall, because they don't have anybody to inform. So once they fall, they can't get to the phone. And then after 12-24 hours, somebody finds out that they are not opening the door, and then they call the ambulance. So it's very difficult for these patients to get help. So my this thing would be to if you know of any elderly people, do uh, call them regularly so that we know they are all well, you know.
Right. Interesting.
And obviously, yeah. And the other thing is, if you have a fall and if you think you have broken something, um, do go to the any straight away, because there are provisions to tackle these injuries without any delay. So don't sort of um, let
Delayed.
it get worse, you know.
Hmm.
Right.
And also,
Correct.
I'll
So a
just add.
delay can be in certain injuries, especially children, small children, where they have elbow injuries or wrist injuries or even lower limb injuries. They can get worse. So do get help immediately, because the minor injuries unit is still open in most hospitals.
Okay.
Okay.
And also, to add on that, the elderly people who fall, they may have other medical conditions. The reason of fall might be medical as well. So while treating the fracture, we also need to rule out heart attack and other reasons of fall. And they may get, if there is a getting the delayed like delayed contact to the healthcare provider, then they might be having developing what we call as rhabdomyolysis. So they get kidney failure because they are lying on the floor for significant time. So, as Sanjeev pointed out correctly, we need to make sure we look after our elderly population and as well as the young people who are both of they are vulnerable. And one of our colleague, I think Santosh Deshpande, he was doing a very great job earlier that he was trying to gather the group like Ani and other UMPEG members were doing that as well to reach out and help the families who are not able to go out and do the shopping for them and other things. So that was a great initiative as well.
Yeah.
Uh,
So Vaibhav, just slightly out of context, Vinita is part of the core group who she's founded this group called Bandhan in Bedford, which is a ladies only group.
Oh, that's
And
good.
they've been doing a lot of charitable work, and they have formed this volunteering group where they have identified these elderly people and assigned a volunteer to each of the elderly people, um, uh, uh, and they do their shopping and are in contact with these elderly people in Bedford.
Oh, that's a great initiative. And
That deserves
I
a round
think
of applause, actually. Very
yeah,
nice
yeah,
initiative.
thank you.
Nice
And
one.
we can use the same model, not in just UK, but in back in India as well. So if somebody is in Goa, India, or somewhere else, like in Goa or Maharashtra or any state, then we need to make sure we have some volunteer helping out the neighbors and getting through it together.
In India, it is easier in the sense as
Yeah.
opposed to the UK. In India, you
Yes.
do
Yes.
have
Yeah.
local help from maids and all that. So
Yeah.
it's not as a challenge as much as in UK.
Yes.
But
Yes.
good
Yes.
initiative.
uh, I have a question, Sanjeev.
Yeah,
My name
yeah.
is Nikhil Deshpande. The children are highly unpredictable. So if they fall or if they fall and landed up in having some kind of a injury, how it is safe to take them to NHS nowadays with regards to this COVID things going around and all that stuff. So is there any
So
alternative, or there is no option rather than taking to them there? For example, if
no, I
somebody's child has got his hand fractured or something happened with the finger which cannot be done at home, we have no option other than taking it to A&E.
Yeah, so absolutely, and that's a very valid question, and it's absolutely safe because what ANEs have done is that they have completely separated the minor injuries unit And also they have even within the minor injuries unit, they have a separate section for children's pediatric unit for these injuries. So as far as the safety in regards to the risk of infection is concerned, it's very safe because it is completely segregated from those patients who are likely to have COVID positive.
And also not just minor injuries as well, like in the area where we are living, we have done a great job to have a minor injury in a separate building altogether, separate from the hospital. But not just, I was speaking with a couple of guys in Newcastle area as well today morning. So basically most of the other hospitals, they have done what we called as a green, red and orange path, or amber path. So those people who are very unlikely to have any COVID infection, they will directly go to green channel. So very low risk of having any, almost like minimal, nil risk of getting any infection as such. Uh, Compared to those people who are red. In red zone, those are all patients who are likelihood of having COVID. So they will go on to the red path. So obviously that minimal risk is always there when you go outside and if you come across any XYZ person. But that is very, very minimal as compared to risk involved of having the complications related to fractures or injuries. So as Mr. Sanjeev said, if you have any major injuries or any fractures, please come and visit to the appropriate department.
Okay, okay. So, guys, time check. Vaibhav also 10:33. We're 3 minutes
Yeah,
over,
yes.
and I think so. This was a
Thank you,
great
Vaibhav. Thanks, Sanjay. Yep.
this was a great
Thank
session,
you.
Sanjeev. Thanks a lot for
Thank you.
coming in and sharing your views, and it obviously helped with understanding what needs to be done. An interesting statistic about the older people falling at home and getting injured. So, thanks again. Thanks a lot. And
Thank you.
with that, we will get started with Vineeta. And I am sure that many people will have many questions when it comes to GP, with especially with the time that's not being, you call them and you're not getting answers. But you don't be surprised if you have too many questions coming from this group, including me. So thanks
That's
for
fine.
coming,
That's
and
fine.
let's get started with your session. Okay, thank you.
Sure, sure.
So, ma'am, what do you think? Like how GP services have been impacted by the COVID, or COVID have made an impact on GP services?
Okay, so it's been a major challenge. Um, but in a sense, we have been prepared from the lessons learned from Italy and all that. We have had that additional advantage of having 2-3 weeks to prepare ourselves. And I think the general practice in UK has done a great job with a lot of guidelines coming from the Department of Health and gov.uk, which has helped us manage our services much better had we not known what was hitting us. So that has been rather useful. Um, if I talk about my own practice, we are a large partnership. We are three practices merged into one, and we have over 40,000 patients. So what we have done is very similar to the hospital. We have created green sites, amber sites, and red sites.
Mm-hmm.
So we do not, at the moment, as per the national guidance, we do not see any patient face to face unless they have been through a phone triaging first, where a GP calls them back, and majority of the times we find that we are able to sort their problem over the phone. We have also got a software aligned to to system one, which is the software we use, on which we can video consult as well. So skin conditions, simple sore throats, coughs, colds, those kind of things we are able to sort either over the phone or through video consultations.
So
After
regarding,
triaging, if we feel that, yeah, hello,
no, no, sorry, yes, please continue. Yeah.
yeah. So if uh, we take them through a triage, and if we are if there is a query that this could be COVID-19, then there is a very good algorithm that most of the local areas have produced, which RAG rates them into um, 1, 2A, 2B, 2C. So the RAG rating is, if you are 1 or 2A, there is nothing to be done. You remain at home, self-isolate, and look after yourself. The ones who are in the 2B category, we prescribe them antibiotics over the phone and then advise them on self-care and isolation and other things. It is the 2C group which may need to be seen by the GPs or may need to be assessed for severity of the condition to decide whether they are safe to be kept in the community or whether they need hospitalization.
Right.
So that is to do with the COVID.
So regarding the antibiotics, so they get like directly go to the pharmacy and get the
So what we do is, yes, we now have most of our patients are on electronic prescribing, and therefore the prescription goes straight to the pharmacist, from where it can be collected. Usually we say give it 24 to 48 hours. If it is urgent, obviously we advise the pharmacy accordingly.
Okay. So, Vinita, what about blood tests? If anybody wants to go in for a blood test, be it for a diabetic every 3 month HbA1c or some other issues that one has, scheduling a blood test right now, calling the GP is being saying that there is a lot of, obviously with the COVID-19, they're occupied with that, and the dates are not being published. So, how does one do that if he wants to get his tests done?
Okay. Now, certainly in our local area, the blood tests for which are absolutely for routine stuff, we are trying not to get people into hospitals. Not because blood tests should not be done, but it is to allow people to remain at home, not come out, and therefore expose themselves and others to possible infections. So that is the reason why routine blood tests are being postponed.
Right.
However, if somebody requires urgent blood tests,
No, but diabetes people would need to check every 3 months, and if it is over
yes.
three
So, for
months,
example, so
yeah,
yes, so if we look at a particular example of diabetes, if let us say we have a patient whose HbA1c has been reasonably okay uh, last couple of times, then it is fine to delay that for another 3 months. However, if somebody is an uncontrolled diabetic or a poorly controlled diabetic, then yes, there is an opportunity for them to get that blood test done. And what we are doing is, even if we are not seeing these patients face to face, the phone calls are still going on, even for
okay,
chronic conditions. So instead of the patient coming in to see the practice nurse or the doctor, we call them back.
okay,
So it
Doctor,
is
just
not as
one
if the
question.
patients are left without any medical input.
Yeah,
okay,
one question here. Like, suppose, yeah, I'm managing my
Yeah.
diabetes well, but because my 6 months checkup are like quite vital, and doctor like suggests to get. So, if I don't get any call any later, but if I'm concerned about my diabetes, so what is an alternative, or what the precaution GP can advise me? Because GP is my first point of contact for everything.
Okay. So most of the GP practices will have a website. Okay. Through the website,
Yeah.
there will be a link. Most of us now have a software called GP Footfall. So if you have any queries and if you're finding it difficult to get through on the phone, just put in that query or email them. It is always picked up by a member of the admin staff and directed to the GP concerned. If the GP, after reviewing your blood test, feels that it is actually vitally important that you do not wait 3 months but get your blood test done sooner, then the phlebotomy services are still running. Not for routine stuff like, I feel a bit tired, therefore let me get my hemoglobin done. But for those who clinically need that blood test, the facilities are still going on.
Thanks. Thank you.
So the modus operandi is calling into the GP and putting in a request and going through the website and putting in a request. That's what your suggestion is.
Yes, that is easier, because then you are not clogging up the phone lines.
Okay.
You are not getting frustrated because you have to wait for 40 minutes because you can't get through.
Right. Yeah, because the
And there
local
are
GP over
different
here,
ways,
we have never tried the website thing with the local GP here, but that is
yeah,
something which
it's
I think
very,
so we
very
can.
easy.
Okay.
Most of us have a website, and there is the GP footfall is a very good thing. I mean, if you haven't tried it, and I'm
Okay.
sure most of the GP practices in this country now have GP footfall, which is a
Is that
very
an app?
intuitive software.
Okay. Is that like a mobile app or is
Yeah,
it
and
like?
it almost sort of guides you. So you say, oh, would you ask a question of the GP, speak to my nurse, I need a repeat prescription. So literally you can go into each room. There are virtual rooms that you can go into and ask a question or request what your
questions are?
what you need, including your repeat prescriptions.
So is this a mobile app or is this a website?
It is also a mobile app, or it is also, if you go onto the GP website,
Okay.
it takes you onto this, and through the website it takes you into footfall, where you
Okay.
literally go from one room to the other. I would like to ask the nurse a question or the doctor a question, or I need a medical certificate, or there are various rooms that you can get into to ask
Right.
that question, and then at the other end our admin staff picks it up, and it is disseminated to the right member of staff to deal with.
So is it the GP staff that's answering that question, or is it a call center kind of concept where
No, no, no.
they
It is our own staff.
it's
We
you?
are
Okay.
doing it. Yeah,
Oh, okay.
yeah, yeah,
Interesting.
yeah.
Did not know that. Good
Yeah. It
information.
every GP surgery is running something like this. It may not be footfall. Others may be using some other software, but
Okay.
essentially we are all trying to reduce um, the number of phone calls we get, purely because it is frustrating, not just for US patients, but even for our receptionists who sees that there are 20 people waiting in the queue, and therefore they are not able to
Okay.
even deal with the problem, with the patient that they're talking to at that time, just because they're seeing that there are 20 other people in the queue.
Okay.
So this is one way of circumventing people calling up and waiting for 40 minutes, 50 minutes, because the phone lines are clogged up.
Okay. Excellent. Anybody else has any other questions?
Yes, I have one question. Hello, doctor. My name is Nikhil, and
Hi,
I have
Nikhil.
a question. Currently, I'm living in Coventry,
Mm-hmm.
and I'm planning to move to Milton Keynes.
Okay.
But because of this COVID things, everything is delayed. My shifting is delayed,
Mm-hmm.
and so is there any standard process where I can take my all records which are in my current GP surgery, and I will have to go and give it there, or something automatically done within the.
This happens automatically. So within the UK, if you move, all
Mhm.
you have to do is, when you move to the other end, you find the closest GP surgery to you, and you just go and register.
Okay,
The
so but the
transfer of
records will.
records,
Mhm.
the transfer of medical records is automatic.
Okay, okay,
If
and
the two GP practices are use the same software, it is almost instantaneous. As long as you say that I am happy for my record to be shared,
okay, okay.
yeah, then it's almost an instantaneous thing that your previous records are seen by your new GP.
Acha. And secondly, we keep visiting A&E sometimes, probably once in 6 months or something like that. So those A&E records, when we go and visit the A&E, whatever
Mm-hmm.
for whatever reason that we visited and all that stuff, will that also get available for the GP, or is the GP needs to
Yes,
ask
they
it
are.
explicitly?
No, that will be on your GP record.
So anywhere in the England, it's supposed to appear in the GP record, right?
Not anywhere in. Well, at the moment, we do not have an ability to do that. But yes, once you move from one GP to another GP, the new GP
Mhm.
will be able to see what has happened to you in the past.
Okay. Because I asked this question because I was working in Woking, and I went to A&E over there for just for
Correct.
my back pain. I slipped from the staircase, and I had that resulted into a small back pain. So I visited there, and later uh, I wanted to trace out the record of it, and I did not get the record. I called on to that hospital, and they said that, oh, we do not have that record now.
But
So
did you inform them of who your GP was?
yeah, everything I have informed them.
Yeah, so even if you get seen anywhere in the country, that A&E should send that information to your GP.
So what
Exactly, and
happens,
when
Nikhil? What happens normally is, although NHS is as the name says, NHS has a big organization, but we have
Mhm.
128 trusts all across the UK. Each trust has its
Okay.
own policy, and each trust is covered by a number of GP under their territory, like in their zone. So the
Mhm.
X-rays have what we call as PAC systems, so a couple of PAC services. So they do share, they are able to transfer the images from one hospital to another. But regarding the notes are concerned, normally when the patient get discharged from A&E, we get what we call as discharge summary. So you can ask for a patient discharge summary, so they can give you a copy of it, that what happened exactly during that visit. So it's a short summary, and sometimes it might be detailed as well, and it goes to the GP practice service, so they do get the update, like what exactly happened to you in that particular admission, and you can carry that discharge summary for the next hospital. But as you said, like, it may not be possible. Currently the system is not designed in such a way that if you move from Liverpool to London, then all data will be transmitted straight away, like from A&E
Okay.
perspective. From GP service, yes, because they have some what you call as summary care record service. So if you have signed for it, then data, GP data, get transferred, but not the A&E one, not at the minute,
Uh,
maybe in future.
okay. Okay.
Not the detailed A&E account, but a
Yeah,
letter from the A&E,
yeah,
which
that
will
can be
have been
transferred.
received by the GP practice,
Yeah,
will be on your record.
yeah, but not exact
Mm.
A&E notes, because they get scanned.
Not the A&E notes,
Yes,
the
yes,
summary of what happened in that
exactly. Yeah.
at that visit.
Mhm.
Okay. Okay.
But maybe in
I have
future
asked
it
this.
should be. Yeah.
Mhm.
Yeah, but
The
let
this.
us say you live in Coventry. Yeah, your
Mhm.
GP is in Coventry, and if you went to Newcastle and went to A&E there, that A&E department will not be able to see your notes.
Okay. Okay. Okay.
Yeah, so it's not as if the entire national, there was a move to do that at one point, but that is still not happening. But if you move from one GP surgery to the other, your new GP
Mhm.
will be able to have a copy of your entire record once the
Mhm.
registration goes through.
Okay.
But at
Okay.
the moment, what the facility we do not have is, say
Mhm.
you live in Coventry but go to A&E in Woking, for example,
Mhm.
the A&E in Woking will not have access to your records.
Okay. Because I can understand they don't may not be having access to that record, but uh, what nowadays this information is some required while renewing the work permits in some cases. So they wanted to see how much is how much is I mean, are you is the person who is going through the work permit renewal, is he due to pay anything to NHS or not? So my immigration lawyer asked me that information, and with regards to that, I tried to find out this information, and I did not get that
Mhm.
information from Woking Hospital. I mean, they themselves did
Mm.
not have this record because I tried
Mm.
calling them, and my
Mm.
GP also not having this record. So I was
Mm.
just
That is unusual,
that was
because
just
if you have given them your GP details, that letter should automatically come to the uh, GP.
yeah. Mhm. And I have another questions. Around a year before, I have given a blood test just to check my triglycerides and the sugars and everything. Uh, but the blood reports are the blood reports available online? Because I checked with my GP and they said that no, you won't get anything online. all that stuff. But is there any plan going forward that the blood reports can be made online or something which we can see easily?
So you got that done in Coventry,
Yes.
and it's a part of your record. Yes, there is the facility. So if your GP practice is use system one, and I'm sure there are other IT guys here who may be able to throw more light on it, there is an enhanced access that patients can have, where you are able to visualize your own blood test results.
Okay.
I
So,
mean, certainly we are able to give a basic access to patients, but there are other patients who request enhanced access. They are able to see their blood tests, their medications online. They are able to book their appointments online. They are able to request their medication online.
Yeah,
uh,
I do get printout of my blood reports when I request for that.
I mean,
Okay, so
for
you
them
get
they
a
just told me.
printout, but yeah, sorry.
For me, they just told me no. I have to walk into GP, and then they will give me the printout of it. I cannot access all that things online, so that was quite
Okay,
surprising to me.
okay,
However,
yeah,
the appointment booking and everything I have done online. That I
okay,
know I can do that one. But I was
okay.
quite surprised that they were not ready to give me online reports.
Okay, so each practice may have their own policy. I mean, we certainly don't have any problem. We have some of our patients on the enhanced data sharing option, where
Mm,
they can see their own blood test results and all that as well.
okay.
Yeah.
So
The
that means it
danger
differs with
sometimes
GP to
is,
GP.
Yes. So
yes, but the facility is there. The problem with this
Okay.
is people, some patients get very anxious when they see their blood test results. They can't interpret it, and then it causes more anxiety than
Mm-hmm. Okay. That makes sense. Yeah. Thank you. Yeah.
just
okay,
just
thanks.
one of our colleague, Vaishali, have just mentioned that she has volunteering for providing hand wash and other equipments for elderly population. So she will contact Vinita. So that will be great. Work like in future, like we all together can come together and help each other and help our elderly population. Yeah,
Sounds very good. Thank you.
yeah. I'll ask her to join your group. Yeah. Okay.
Okay, guys, time check. 5 minutes from closing this call. So I think so. Let's call it a day. And thank you, Vinita, for your time
Yeah,
and
thank you, thank
answering
you.
all the
I was
questions.
expecting a lot more questions. You guys were a very easy lot.
Oh no, well, it's like the Confucius saying, the more you know, the more you know that you don't know. But we have just 1 hour, as we could keep going and going. So, but we
Hello,
have
sir.
this discipline over here that we are trying to do
Hello.
it within an hour. Yeah, who's this?
Hello. संतोष वैशाली मंत्री here. Hi विनीता,
Yeah.
मी वैभवला मेसेज केला. तर
Huh.
we'll take that one on one. पण क्विकली सर couple of minutes असतील आणि
Yeah.
तुम्ही
Just
जर
give us
थोडंसं
time.
गाईड करू शकला. Especially yesterday आमच्याच एरियामध्ये 13-year-old boy he died without any condition. आणि खूप सारे पेरेंट्स आहेत. तर एक काही पण just few tips if you could give, because so many children are at home. Would be nice.
Okay. Now, from what I understand from today's information is, they are not absolutely sure that this little boy has passed away as a result of COVID-19. So we are still waiting for the coroner's report.
And I think to add that on, obviously there is an element of anxiety is there. But as we discussed earlier, in the pediatric population, so say for example, if we have 100 patients coming with the symptoms of COVID-like symptoms, only 2 or 3 people, like 2 or 3 children, will have COVID positive, as compared
Correct.
to adult
Correct. It is.
population. And we have more other number of patients like with the picorna virus, paramethanephrovirus, which were discussed in the past. But as we said, like there are few cases, but they're less as compared
They are
to
very, very small percent. Very small percentage.
and even they will have even if they have it, they do have some other underlying conditions which makes them vulnerable, like having blood
Different age group
cancer.
ऐकलं ना आपण आता. There was a 19-year-old, 21-year-old. So I was just
No,
personally माझ्याकडे 30 वेगवेगळ्या एज ग्रुपचे चिल्ड्रन आहेत. I just
अच्छा.
thought for everyone, like आपल्या सगळे फॅमिली मेंबर्स आहेत.
Yeah,
any
so
particular
the
tips or
advice is
anything?
very standard and very the same for everyone, unless you belong to a high risk age group. Okay, nobody is completely immune to this, konala hi ho shakta, but the chances that people with comorbidities and other illnesses uh, doing worse than people who do not have any existing illnesses is much higher. The advice is standard: do not go out, keep yourself away from people as much as possible, wash your hands, um, all that standard advice. Now konala hoil ani who will do badly, chances are that people who are otherwise fit and well are going to do well with the virus and are going to only have a mild illness. It's only going to be that very small percentage of people who have other illnesses and comorbidities who may not do well with the virus.
डॉक्टर मग आज जो आपण स्पाइक पाहिला ऑलमोस्ट 561 चा तो तो हॉस्पिटलाइज पेशंट्सचा होता की इट कुड बी लाईक अ जनरल फिगर फ्रॉम ऑल्सो पब्लिक हु आर नॉट हॉस्पिटलाइज एज सच.
So majority are the hospital statistics.
So just to emphasize, today's total count of UK currently is 29,500, which we predicted couple of days ago, and the death count is almost like 2,300. So as we were saying earlier, and as we spoke yesterday as well, that as days goes, next couple of weeks gonna be critical. So please follow the advice, stay at home, try to avoid unnecessarily contact, and yeah. And
We are
thank you so much.
expecting next week to be a sharp peak
Sharp peak.
around Easter time. We expect it to be at its worst.
Yeah. Yeah, that is what we are emphasizing every day in our calls. Just stay inside. Just do not step out.
Yeah,
And
it is very critical that people do not go out if they don't need to.
yeah.
Yeah, Dr. Vaibhav, last question. Is your test out now? Like you were mentioning about the.
No, even we haven't been offered it yet.
No, not that one. So what I was like, what is happening is probably Vineeta, you're not aware of it. So I can share actually because some of the hospitals are aware now. So I have developed an artificial intelligence based software where the X-ray gives us a diagnosis of COVID-19 with a specificity of 99.9% and a specificity of 93%. So currently the software is ready to go, and it has very good outcome. I mean to say, the software has very good outcome comparing the other tests available in the market. And we are currently in liaise with 5 major teaching university hospitals in UK, namely Addenbrooke's Hospital. Then there are 2 more hospitals. I cannot disclose the other hospital's name yet. And we are doing the external validity of the proposed innovation as well. So hopefully we'll get in next 24 to 48 hours, maybe by Monday. Once I get the external validity, because there should not be an element of bias, because I am proposing the software, so it should not happen that it's a bias from the developer. So we are getting it from other 5 different hospitals as well, from different parts of the country. So once we get their results matched with us as well, so we're gonna go live maximum by Monday. And if there is any further delay from the hospitals because of any reasons, any legal reasons or whatever is the reason, in that case I'm gonna keep the software live by Monday for sure, and it will be available across the globe for all 199 countries, free of cost, no cost. There just need to upload X-ray and get your results straight away. But this is not officially like I didn't officially launch, didn't explain earlier, although we had interviews scheduled with BBC and CNN tonight, but we have postponed it for we waited for the external validity of the test.
Fantastic news.
So
Fantastic. Great
this is
news.
brilliant. So when are we
Yeah, so
likely
this
to
is
get
ready. Yeah, so this is the product is ready. We are like as early as the other hospitals come up, I'm happy to go live. And on top of that, there are a couple of prestigious hospitals back in India. We have spoken with them as well, and they are also agreed to go ahead with it. So I just need a few more hospitals to, like, I was wanted as additional extra external validity, so that make sure it's repeatable and accurate. I know, although we have made this based on the open access data on a bigger scale, and it's quite accurate. I'm quite confident about it, but I don't want any even a minor amount of bias involved in it. So hopefully down the line picture will change, so we don't need to get too much worried about uh, uh, different modalities of test. Say those people having fever, cough, chest pain, or fever, cough, or any related complaints related to the chest and fever, if they have their X-ray, they'll get the quite accurate test, with the normal
But get
test with the accurate result.
But
but
that is once the
X-rays,
respiratory, yeah. So that this is
yeah.
for the slightly later cases where there are respiratory symptoms.
Yeah, because what we found that even if we do the RT-PCR test for nasal swab, in earlier cases you can have false negative test. So that element was there. So and even if the test come negative at the beginning, or even if come positive at the beginning, the advice remains the same, to stay at home. But doing this probably will help on a bigger scale. So we're just trying to sort out how we can implement, and it will help specifically to the poor countries and developing countries, so that they don't need to wait for the costly tests. So it's an easily accessible X-rays. They are available all across the globe, and the results are instantaneous. Literally, like, you upload the images and you get it like straight away within less than 5 seconds. So yeah.
Very nice. Very nice.
Brilliant, doctor.
Impressive.
Congratulations. Thanks.
Yeah.
Yeah,
Congratulations,
great,
doctor.
great.
Yeah, excellent.
Yeah. So
Okay,
hopefully that
guys.
will help the community. Yeah.
Absolutely. So,
Mhm.
Vaibhav,
Congrats, congrats.
3 minutes over, and I'm conscious about the time as
Oh,
we do
sorry.
every day.
Yeah.
So, while
Yeah.
the information is vital and critical and good,
Mhm.
we don't want our special guests invited to
Yes,
stay
yes,
for a
it's true.
long.
Thing. Yeah. But
So, without much ado, I think so. Guys, let's close this call. And
Mhm.
having said that, thank you, Sanjeev and Vanita. A lot of
Thank you.
information
Thank
in
you.
this 1 hour,
Thank you.
and real
Thanks,
pleasure
doctor.
talking to you guys. And as I said,
Yeah, like
everybody, this recording is available on the YouTube channel, which Vaibhav has created, UK Lifesaver. So you can go back to that channel and like, subscribe, comment over there. So if
and share.
everybody is good, can we close the call?
Yes, please. And thank
Yeah,
you,
thanks once
Sanjeev.
Thanks,
again.
Thanks a lot. Thanks,
thank
guys.
you,
Thanks.
guys. See you
Have a
as
good
well.
night.
Take care.
Thank you and
Thank
congrats.
Bye.
you.
thank
Yeah,
you,
bye.
Thank
thank
Bye.
you.
Bye bye.
Bye. So how to leave the call? तो phone was later.